Good evening, everyone. A quick thank you to the organizers for the opportunity. We are at the fag end of the day, and I'll just try to keep it quick. Two simple abstracts for me. The first one that I'm discussing is the effect of peritumoral infiltration of local anesthetic before surgery on survival in early breast cancer patients, conceptualized right here in this institute, the principal investigator being Dr. Rajendra Badwe. A lot of us here have been part of this trial. The rationale for this was altering events at the time of surgery can prevent metastasis in early breast cancer. There is preclinical and clinical evidence of surgical dissemination leading to METs. The hypothesis is acute hypoxia induced during surgery can activate the pro-metastatic pathways, mostly through voltage-gated sodium channels, and local anesthetic agents are known to block these channels. So we'll discuss the study design, but the primary endpoint was disease-free survival, the secondary endpoint being overall survival. So here is the design. Non-metastatic early operable breast cancer patients with clinical N0 or N1 lymph node status were included. Any tumor with prior intervention, either with respect to surgery, that is biopsy or excision, or neoadjuvant chemo or endocrine therapy were excluded. This is the methodology. Lignocaine in specified doses was taken, diluted, and injected all around the tumor, namely the 6 surfaces. This is after the induction for surgery, and around 7 to 10 minutes after the injection of the local anesthetic, the planned surgery was carried out. This is a consort diagram, 1600 randomly assigned to the 2 arms, and final eligibility number for analysis was 786 in the LA arm and 797 in the no LA arm. Recruitment was from December 2011 to October 2018. We have seen the numbers, 786 versus 797, total of around 1600, stratified by menopausal status, tumor size, and center. Median follow-up was over 5 years, that is 68 months. Now, this is a busy slide with the clinical characteristics. In short, they were mostly equally matched across the 2 arms. Of note, the median age was around 51 years. The median tumor size was 3 centimeters. The grade mostly grade 3 tumors. Lymph node positivity and negativity almost equally distributed. Around 60% underwent breast conservation, 40% underwent mastectomy. Around 66% needed full axillary dissection, and the remaining had some sort of conservative axillary management. The distribution of hormone receptor status and the adjuvant therapy was as per the prevalence in the population and the guidelines. The important results, the 5-year DFS rate in the local anesthesia arm was 86.6% compared with 82.6% in the no LA arm. You can see the separation of the curves there, and this result was statistically significant. The 5-year overall survival in the LA arm, 90.1% versus 86.4% in the no LA arm. This result in figure B is also significant, and you can see the separation of the curves there. Also, the loco-regional recurrence rates were seen, and that was lower in the LA arm at 3.2% versus 4.1% in the no LA arm. The 5-year cumulative distant recurrence rate was also lower in the LA arm, that is at 8.1% versus 10.9% in the no LA arm. Basically, all these numbers, the LA arm has better results than the no LA arm, and all the results are statistically significant. On performing multivariate Cox regression analysis for various factors, it was found that the study intervention was significantly associated with both DFS and OS benefit with most of the factors. Subgroups that were determined according to the pre-specified stratification factors and the known prognostic factors, when analyzed for the effect across these subgroups, it was seen that the effect of LA was similar across the groups with respect to both DFS and OS. So the conclusions, in patients with early breast cancer, peritumoral infiltration of lignocaine at the time of surgery can lead to statistically significant and clinically meaningful improvements in survival, both DFS and OS. The reduction was seen in locoregional recurrence as well as distant METs, and this benefit is evident across all subgroups. So the strengths of the study, the sample size is good, multi-center participation was there, inexpensive one-time procedure, no training required, good compliance seen with respect to adjuvant treatment in the patients, and the absolute benefits in DFS and OS both of almost around 4% in each seem to be clinically meaningful, are shown to be clinically meaningful. Some limitations though, no placebo injected in the no LA arm, It was an open trial. The investigators and the surgeons were not blinded. The molecular mechanisms are not exactly proven, although the samples have been taken in this study with respect to the effects of hypoxia at the molecular level, which is the hypothesis of this trial. But that is underway, and that will probably be brought out soon. A small population, that is the HER2 positive patients, only 1/3 of them received the HER2 positive treatment due to financial constraints. But this group is equally matched, or this number is equally matched across both the groups, intervention and the non-intervention groups. However, the neoadjuvant therapy population was not included in this study. It was only early breast cancer. When I went through literature, I saw that there are various studies on the role or the beneficial effect of local anesthetic with respect to cancer, with a myriad of mechanisms also shown. So my take home would be that this is a simple low-cost intervention which is easy, reproducible. There is no discomfort to the patient. It is under anesthesia. The results are impactful. And of course, futuristically thinking, can the effects be generalized to other solid organ tumors? Can other VGSC blocking agents, possibly like cannabis, be brought into the armamentarium as well? But I think those studies are still underway. So with these thoughts, I go on to the next abstract. That is impact of F18 labeled PET-CT versus conventional staging in patients with locally advanced breast cancer, published by Ian Davis in the JCO last year. So the objective outlined was in LABC patients, does staging with PET-CT detect more distant mets than conventional staging? The conventional staging in their case was CT, thorax, abdomen, pelvis, and bone scan. Primary outcome being upstaging to stage 4, and secondary outcome being change in the intent of treatment, that is from curative to palliative. The inclusion was stage 3 and stage 2B patients, N2s, T4s, T3, N0. Any patient not undergoing neoadjuvant treatment was excluded. Stratification was by inflammatory breast cancer and clinical center. After recruitment and eligibility analysis, the numbers in the PET-CT group were 184, that in the conventional staging group were 185. Clinical characteristics of note, the mean age was around 53 years. Majority of the patients were stage 3A, and the mean tumor size was quite big, that is more than 6 centimeters. This is across both the groups. Regarding the primary outcome, you can see the numbers there. More than twice as many patients were upstaged in the PET-CT arm compared with the conventional staging. Those are the numbers, 23% and 11%, the absolute difference being 12.3, which was statistically significant. Relative risk, 2.4, as we saw, doubling of the number. The sites, PET-CT detected more mets across most of the sites, that is bone, mediastinal nodes, lung and liver. In the conventional group, the most common site was the bone, and occasional visceral mets were detected. One point to note was that with respect to regional nodes, 97.7% upstaged PET-CT patients had positive regional nodes compared with only 61.1% in the conventional group. Analysis exploring heterogeneity. This is the figure of analysis exploring heterogeneity within subgroups and the relationship with upstaging. And here we see that the tests of interaction are not really statistically significant across the subgroups. So not like one particular subgroup influenced the finding. When the secondary outcome was seen, out of the patients who were upstaged in both the groups, 81.3% patients of the PET-CT group and 95.2% patients of the conventionally staged group, they had change in treatment. That is, they did not receive the curative intent combined modality treatment. The absolute difference here was also statistically significant at 8.2%. So the conclusion was that the authors advocate PET-CT for routine staging of patients with clinical stage 2B and stage 3, and this has also influenced funding in their country. There are a few strengths. It is a randomized trial. It does test the utility, that is a impact of the outcome with respect to change in treatment. And where the changes where there is a change in stage 2 M1, they avoid getting the aggressive treatment, hence avoid the toxicity of the treatment, as we know with a lot of M1 metastatic breast cancer trials. However, there are a lot of limitations. First to note was that they said that in the upstaged patients with PET-CT, only 80% received change in treatment. So why did the 20% did not receive change in treatment? Why were they continued with curative intent treatment even when the stage was upstaged to stage 4? So was it due to the presence of asymptomatic mets? This is all hypothetical. They have not provided the data. So there is some missing information there. Was it due to oligometastatic disease? We all know that oligometastatic disease we treat aggressively now. It is treated with curative intent. So is it that part of the population was that? And if that effect is taken off, then does the effect still remain significant? Does the positive effect still remain significant? Of course, the false positives detected on PET would be a limitation. I did go into the NCCN guidelines, and they say that PET-CT may be helpful in identifying unsuspected regional nodal disease and/or distant mets when used in addition to standard imaging studies when they are equivocal or suspicious. So my take-home would be that conventional imaging, we cannot yet throw it out of the armamentarium. However, where resource availability and finances are not a concern, PET-CT may be considered, but the confirmation of the additional findings seen on PET, maybe with additional procedures, needs to be kept in mind. And definitely there are certain scenarios where PET can come handy as a problem-solving modality, or when there is second cancers in such kind of scenarios. Thank you.